Thanks, Ray. Um, Hello, everybody. So hopefully the screen is showing up. Did it pop up? Okay. And hopefully it will respond. All right. So when Dr. Beal asked me to do this, and by asked, I mean told. When Dr. Beal told me to do this, um, this month's topic is thinking about the overlap of substance use with a lot of the other factors that we address. And the opening discussion was targeted for screening and assessment, thinking very specifically about substance use needs. And when we think about that, hopefully we're thinking about ones that are a little bit older on the spectrum that we address in this echo. Sadly, not always, but typically we're falling in the adolescent range someplace, and that's a pretty big range. And as I tried to put something together that would just be a 15-minute, really quick introduction in terms of screening and assessment considerations for this specific population, I didn't do a great job in terms of keeping it just to the screening and assessment, like here's some specific tools. So really this is kind of a bait and switch. I know nobody showed up today for the didactic. This is kind of like the cartoon at the beginning of the old time movies. You know, you kind of get what you get. So that being said, I don't feel too bad about the bait and switch. It's really going to be more about foundational considerations about who we're serving. We are serving kids with a lot of areas of need. And thinking about the addition of any kind of substance use in that, the largest range is going to be with adolescents. And so really quite a bit of my 15-minute ramble this morning is it's still morning. This morning is going to be about considering things through the perspective of this developmental period, and that's very important. My focus at the Center for Innovative Practices, where I am, Dr. Shepler's my boss. My focus is primarily youth with co-occurring mental health and substance use needs. And that's how it started. But over the last 8 or 10 years, really it has expanded considerably. And that's going to be part of the discussion here. When we're thinking about co-occurring disorders, when you hear that referred to, very specifically, this is a co-occurrence, an overlap of something on the mental health side and something on the substance use side. So that's globally. More individually and specifically, this is coming from SAMHSA. This is out of TIP 42, the Treatment Improvement Protocol manuals that many of you are probably familiar with. 42 is specific to co-occurring disorders. So more individually, specifically thinking about co-occurring disorders, when at least one disorder of each type can be established independently of the other, it is not simply a cluster of symptoms resulting from one disorder. Now we're going to expand on this consideration, but this is really important. Very often, and historically this was really the case, it's less so now, but it's still easy to fall into this trap in terms of thinking, well, the behaviors might be a result of the kid's substance use, or vice versa. More often than not, it is the behaviors are the result of the substance use itself. So, you know, the youth is smoking marijuana every single day. And so the oppositional defiance stuff that we're seeing is probably a result of the drug use. And we can't really figure out what's going on the mental health side until we figure out what's going on the substance use side. We've learned through a lot of experience, a lot of practice, and it started, the considerations started on the adult side and have been backed up to the adolescent side. That if there are needs there, they need to be identified. They need to be identified independently. They need to be addressed on an equal footing, on an equal basis. Because if we just tackle one side and not the other, then it's a disservice to the individual, and it's really going to slow down treatment. So I've got a lot more to say about that, but I want to touch on quite a bit of what I put in here. I put in way too many slides to talk about in 15 minutes. Whenever I put these together, I get paranoid that I'm going to, in a 15-minute discussion, I'll be done in 7.5 minutes. And so I always put in more than I can cover. While we think about disorders being identified independently, so something on the mental health side, or some things very often as we talk about on this echo, some things on the mental health side, and then something on the substance use side, or some things plural, being identified as independent entities that we can identify. So something on the depression side, something anxious on the anxiety side, and then maybe some cannabis use and some alcohol and some nicotine on the other side. All of these being identified independently, and that's important to do that for the understanding and for the etiology, but nothing exists in isolation. So with co-occurring disorders, which when I really first started thinking about co-occurring disorders, I thought this is about as complex as it gets, which was really being happily naive. Because there are so many other things that get added into the considerations and into this conceptualization. But these things don't exist in isolation. So the mental health, yes, we can identify it independently, but it's going to influence the substance use, and vice versa. The substance use then will influence the mental health, and then it expands beyond that. And I'm going to talk about that in a minute. Related to the developmental considerations, something that I am moving towards, and I'm not really sure if this is just a semantic argument, if this is more purposeful behind that, and I'm leaning towards it's more purposeful, that when it comes to adolescence, I'm moving away from saying disorders until we're really certain about what's going on, and using the term needs rather than disorders. So, and that's a semantic consideration just because of what's going on developmentally with the opportunity for change working with adolescents. So I'm not going to get on my soapbox and talk about how I think, in my very biased opinion, and mine is very biased, but in my very biased opinion, working with folks during adolescence affords us the best opportunity for long-term positive trajectory change because of the plasticity that is available during this period of life. So I'm not gonna go down that rabbit hole. I could, and it would go on a lot longer. Our consideration of co-occurring identification and then matching treatment to the identification, starting with co-occurring, has expanded considerably. And so the first thing that we have recognized is that when there is something on the substance use side and something on the mental health side, some things, typically there's more than just one on each side, very often then we also have the inclusion of historic, complex, or developmental trauma, and then also individual experiences of trauma for that youth that are involved in the interaction of mental health and substance use needs. You know, if you think about a 13-year-old who is smoking marijuana daily and is depressed and anxious and impulsive, very often that's going to influence that youth being in situations that could potentially be pretty traumatic. And so there is both a background of complex or developmental trauma that we often see, not always, but often, and then it's not uncommon at all to see these individual traumatic experiences that are involved in influencing in both ways. So we expanded in terms of our conceptualization to include trauma separate. And when I first started, I was very guilty of including trauma on the mental health side, but it's very separate, and really it's a benefit to the youth, to the family, and to us on the clinical side when we start considering that separately. So very strongly identified substance use needs in adolescence predicts the likelihood of co-occurring mental health at an over 70% rate. That is, as if there is substance use needs or disorders identified in an adolescent, there is over a 70% chance that there is a co-occurring mental health need, at least one, for that youth. Predicting the other direction, if mental health needs are identified first and a referral is made that direction, there's only, and that's with little air quotes, there's only about a 40% chance that there could be co-occurring substance use there as well. So there is an expectation working with any adolescent, really any door that they come in, that there is good reason to suspect that there's going to be needs across a broad spectrum, which then takes us back to the bait and switch part, the original. This was about screening and assessment. Screening and assessment, especially the screening, needs to be done initially and then on an ongoing basis, because there can very well be needs across multiple areas. If you have been a part of any of our ECHO presentations, you know that things very quickly get more complex than just, and again, that's kind of an intentional, ironic statement, than just the overlap, the co-occurrence of mental health and substance use. That there are a lot of other domains that there can be needs in, he said, ending a sentence in a preposition. So in our consideration of cases in ECHO, very often there are needs in more than just two areas, in more than two dimensions, and it expands very quickly. So our considerations include trauma, substance use, mental health needs, and the combination of substance use and mental health was our starting point with co-occurring, but it expands beyond that very often into what we refer to as multiply occurring areas of need. And again, these areas can be identified independently, just like with the definition of co-occurring disorders. They can be identified independently, and the next slide really kind of highlights some of those. This is not exhaustive. This is just some examples. You know, on the trauma side, we can identify areas. The substance use side, is there a difference between a youth who is using just marijuana or is maybe throwing in some alcohol, some nicotine? The dissociative use is indicative of a lot of trauma a lot of times. Mental health side, we consider internalizing versus externalizing, endogenous versus exogenous, things like that. On the developmental disability side, a lot of areas that can be identified independently. On the biomedical side, a lot of areas. And I threw in ones that I commonly saw displayed by youth living with a lot of mental health needs, things that were pretty common to that. So all of these areas can be identified independently of each other, but they don't just exist independently. They have interactions. They influence each other. They can exacerbate each other. They can mask symptoms on the other side. So it's very important that we do screenings, not just at intake, but on a regular basis to help that youth, to help the family, and to help us as a clinical team to identify different areas that could be influencing these other areas. So this slide I threw in here, none of these slides were created just for this, they're pulled from other presentations. This one was in here as a backup in case I was going too fast and I ended too early. But I did want to include this as a recommendation. If you're not familiar with the resources available at the National Academies, the National Academies of Science, Engineering, and Medicine, this was a publication within about the last 18 months that I strongly recommend to anybody who really at any clinical avenue works with adolescents. It's the promise of adolescence. And the next slide is just more stuff that's available through the National Academies, focusing on childhood and adolescence that's available. These are some topics that came out just in the last year and a half. And I encourage everybody to go to the website, nationalacademies.org, and sign up. You can become a member for free, and then you sign up for your areas of interest. And there's a lot of great resources working with the family system stuff that we really focus on, and well beyond that. The foundational focus of thinking about screening and assessing, and certainly beyond just substance use, all of these overlapping areas, when we're working with, when we're serving youth, that is in adolescence, we really have to take the perspective of adolescents. Adolescents are not adults. Adolescents are not children. They are a very purposeful period of life with a lot of hallmark and descriptive things that are present just during adolescence, right? There's the active physical development, sexual development, the ongoing brain development. It is the second most active period of brain development in our lives after infancy, which every time I say that, it amazes me. The second most active period of brain development. You'd think it would go in a stepwise fashion from infancy and then step on down until transition age, but things really pick up. There is a lot going on during adolescence. If you work with adolescents, or heaven help you, if you have an adolescent at home, I mean, you know that on a firsthand basis. Adolescents are tough to understand under the best of circumstances. So with our consideration of all of these different areas where youth could have needs, trauma, substance use, et cetera, every single teenager in the world is trying to balance what's on the right side of this, which is that active brain development, the ongoing physical maturation, the ongoing sexual maturation, and all of the pulls and overlapping needs and directions that are associated with that. So if you've ever worked with an adolescent who came to you with, a previous history of, this is definitely bipolar 1 and 2 disorder, and we're pretty sure that there's some foundational personality disorders going on, that is kind of descriptive of what's going on with adolescence. It's not accurate, but it can be descriptive. So I'm just about out of time, and I definitely don't want to take time away from our team, but the individual considerations for our adolescents are very complex. There's a lot of different areas of potential need. There's a lot of different areas of confused understanding of what's going on in every single adolescent just because of what's normally going on. So getting a picture of that takes a lot of overlapping screening and patience and ongoing screening. But adolescents don't exist in isolation, right? Hopefully the family is the most important component in their life, even though adolescents don't always view it that way. Families don't always feel that way. But then there is also the considerations of the influence back and forth from family and from the other domains around the youth. So all of this, and this is coming again from tip 42, the treatment improvement manual, 42, that failure to routinely screen clients leads to a cascading event where we don't identify things. If we don't identify things, we don't understand the influences of what's going on with that individual, and then we can't appropriately match treatment to that. So it starts with screening. And I'm going to say it starts even before that. It starts with an understanding and a recognition that there is the likelihood of multiple areas of need that are present in adolescence, period. And when we get into the multi-systemically involved youth that we're talking about, we already know that. And so it's important to screen routinely, not at intake, not just at intake, but routinely throughout. And so that's what this slide kind of represents. Now, because I know none of you have plans tomorrow morning from 9 to 12:15, and this is by no means extremely short notice, if you would like to hear me ramble on almost endlessly, that is for 3 hours about screening, assessment considerations for youth and adolescents, Ohio Moss is sponsoring a training dedicated to screening and assessing adolescents with co-occurring and multiply occurring needs tomorrow. You have to pre-register for it. I will put the registration in the chat box if you can get free tomorrow morning. There's free CEUs, counselors, social workers, nurses, I think psychologists. And that's it. I'm out of time. I have a lot more to say, but I am out of time. So foundational considerations, thinking through the lens of adolescence, recognizing that there are a lot of potential areas of need that we should always be aware of. And if we just focus on one area and ignore the others, the likelihood of positive change is very low. So that's it.
Thank you, Mike.